In this video we will concentrate on intraocular lens features and certain aspects that one must keep in mind when choosing the right intraocular lens for patients. The characteristics and features of all IOLs can be broadly clubbed into the following heads: material, design, optics and delivery. All the features of an IOL that fall under material will provide the benefit of clear anterior and posterior capsule post-operatively, with minimal or no opacification of the IOL optic in the years to come. The features of IOL that can be clubbed under design should help the doctor to achieve greater refractive predictability, including rotational stability in case of toric IOLs. The features that can be bucketed under optics delivery should provide benefits of better image quality with less dysphotopsia. And lastly, the feature that comes under the delivery of lens should provide safe, uncomplicated lens implantation. In this video, we will discuss on the material aspect of choosing the right IOL. Post-operative capsular opacification involving both posterior and anterior capsule is not related to IOL material alone. David Apple had proposed 6 factors for the reduction of PCO, which were 3 IOL related and 3 surgeon related. Amongst the surgical related factors are in the bag implantation, a thorough IA and cortex removal, and a capsulorhexis of less than 1 mm of the IOL optic size, to help have a shrink wrap effect of the anterior capsule on the IOL optic. The 3 IOL related factors that would contribute to less PCO are capsular biocompatible material, square edge design, and adherence of IOL optic to posterior capsule. One way of reducing cell migration from the equator of the capsular bag to the posterior capsule is to make the IOL posterior optic adhere to the capsular bag. This would ensure less space for cell to migrate and grow on the posterior capsule. This is the most noticeable feature of the Acrisov. The adhesion of the posterior optic of the IOL to the capsular bag has been considered to have prevented the migration of equatorial lens cells towards the posterior optic. Some companies have deliberately incorporated changes on the posterior optic of their IOL to promote more fibronectin binding. The Vivinex IOL has a special active oxygen treatment on the posterior optic to enhance fibronectin bonding to promote adhesion to posterior capsule, in what could be regarded as a sandwich effect, long described by Reggio Linola. The lens undergoes an active oxygen processing treatment to reduce the chances of PCO after cataract surgery. The second important feature of an IOL that may help reduce PCO is the square edge design, that is incorporated in most lenses worldwide. But the question remains, how square is the square edge of the IOLs? Recent papers like Nanavati and co-authors show us that the square edge profile of all lenses are not the same, and that the sharpness of the square edge profile greatly varies from IOL to IOL. Apart from the features that were described by David Apple, several new features have been identified to play a role in postoperative capsular opacification prevention. These are surface roughness of the IOL, water contact angle, and surface charge of the IOL. Several papers have postulated that surface roughness may directly impact lens epithelial migration onto the IOL optic. Tanaka in 2005 was one of the first authors pointing out to the direct link between surface roughness of IOL and lens epithelial cells migration. Higher surface roughness may be associated with higher cell migration. The same study also drew a relation between water contact angle and cell migration. Contact angle is the measurement of angle of contact between a drop of liquid and the IOL surface. The higher the contact angle, less spread of the liquid on the IOL surface. Therefore, less chance of lens epithelial cell migration on the IOL surface. For more information, follow quickguide.org.